And then we're now coming back to Lisa. So I hope everyone in the department saw the announcement that we sent out, where it was an incredible opportunity to celebrate her many, many accomplishments. I'm not going to go through it all here. I will just say, I think many of you know that Lisa has been named chair of the Department of Pediatrics and director of the Steele Research Institute at the University of Arizona College of Medicine, effective March 1st. Lisa, we will have a celebration here at the end of the month. During the Q&A, Lisa's slide is going to go up with the details of that celebration, because we have so much to celebrate. I don't want to take much time away from Lisa, but I hope all of you are very well aware of her deep impact, whether it's the STAT residency program and building, I just think, an incredible cohort of the next generation of fierce advocates for child health, everything that she's done in scholarship, the engagement of so many divisions, so many faculty and staff through the Office of Child Health Equity. Her accomplishments are really quite profound. And if you haven't seen that announcement, we can make sure you have a chance to see it, because it really goes through all of her accomplishments. I don't want to take all the time to do that here. Just going to give the floor to Lisa. So Lisa, welcome.
Well, thank you very much. I'm so appreciative and would like to start by expressing my thanks for this honor of presenting here at Grand Rounds. Mary asked me to come and not talk about the OCHE and all of that work today. I'm really going to be focusing on my science, and we'll be talking about pediatrics and early childhood education, team science for systems change. These are my disclosures. The work I'll be talking about, the funding is listed there. I'm very appreciative to the National Science Foundation, NSF, and quite a few foundations who have supported this work, as well as discussing these clinical trials which have been registered. So this is a Grand Rounds in 3 acts. First, we'll be talking about advancing the evidence for thriving children and transdisciplinary science. So we'll review the evidence-based approaches to all children thriving via school readiness. Second, we're going to move into pediatrics as a team sport, advancing the evidence with team science to promote systems change. And finally, what's past is prologue. What is a good mindset for the future as we cope with and move into today's context? So one of my favorite things is when Grand Rounds starts with a case. So I want to start with a case. This is a picture taken from the Ravenswood City School District webpage. So this is the school district in East Palo Alto. And you can see here 4 gorgeous kids, very different temperaments, you can see. But what they all have in common are bright eyes. These are kids that I took care of for, not these specific children, but likely one of them probably, for 14 years in East Palo Alto when I worked as a primary care pediatrician at Ravenswood Family Health Center. And at that clinic, I saw patients directly. I did not precept. And that was a deliberate choice. I loved seeing the patients, knowing the families. And I took many families from birth up through middle school. And really watching these children grow changed how I saw what my job should be. And that's what I'm going to talk about today. So this clinical case it's an amalgamation. It's it's not one kid in particular, but an amalgamation of much that I saw. So a 4.5-year-old has come in for a school physical. It's an inquisitive kid, healthy generally, very interactive, kind of precocious, bilingual, perfect in Spanish, pretty good in English, but doesn't know a lot of basic things. I would ask, what's the color of my jacket? What's the color of the paper on the table? English or Spanish? What's the first letter of your name? And I was so struck by that because these are super bright kids and I know what a 4 or 5-year-old is capable of. And so I started to wonder, I started to get really frustrated. What have I done wrong? I've known this kid since he was born. Why isn't he really ready to go to kindergarten? I gave him reach out and read books every time they came in. But was there more that we can do? And it was really my public health training that taught me when you see a pattern, start to look at systems. Don't look at the individual parent and blame, right? It's like if there's a pattern here, there are systems at play. And so what I was really inheriting was what was happening in East Palo Alto. So let me tell you a little bit about that community. It's so close and yet so far. I'll orient you to this aerial picture here. On the upper right, you have Palo Alto, and the bottom left, you have East Palo Alto. You see the 101 running right through the middle. And you've got the land of IKEA there, kind of the blue. and what used to be Whiskey Gulch over there, the new Four Seasons across from it. Everybody remember Whiskey Gulch? That was, yeah. So with this new development, East Palo Alto has more tax revenue, right? So that's part of, it's a big contention whether or not to do the development in both of those areas, but it does generate more tax revenue for the community. But what's the first thing that jumps out at you with this picture? What strikes you about the difference? Green, right? So the trees are more thriving. There's more of them and they're thriving in Palo Alto. It's not that the weather's different. It's not like that's landfill out there. The soil's the same. The difference is the amount of resources and policy. And it's the same thing for kids. The kids and the trees thrive in Palo Alto because of resources and policy. So I kind of want you to hold that in your head as we move through today's discussion. So one of the best ways to look at child poverty and child poverty rates is how many kids qualify for free and reduced lunch. So in California overall, free and reduced lunch is about 52% of the children in California qualify. So about half the kids in California live in poverty, which we know. But as with so much data, you don't really know the story till you disaggregate it. In Ravenswood City School District, about 90% of the kids qualify, and in Palo Alto, 10%. So you can just really see how deeply segregated we are. The next indicator we're going to look at is third grade reading level. And this is really an important concept. So in the education world, as you are going up towards third grade, you're learning to read, right? So the focus is really making sure every kid in third grade can read. Because after third grade, you're reading to learn. Everything is going to come at you in the written word. So if in third grade you don't read, you're going to fall behind, not just in reading, but in all of the subjects. So third grade reading level is really important. So where are we in California in terms of third grade reading level? So brace yourself. This one hurts me. Overall for the state, only 44% of our kids read at third grade reading level. And again, when you disaggregate it, only 9% of the kids in Ravenswood and 76% of the kids in Palo Alto. And this just feels to me like an emergency. And it wasn't until I started looking at this that I was, this is what I was feeling in clinic. I was seeing it over and over. So if you're having trouble reading, there are people in schools that can help you, right? California school personnel, some ratios here, reading specialists, special ed teachers, things like this. So in California overall, the ratio is about 240 kids to one specialist, not the teachers, but the other type of personnel. But the ratio in Ravenswood is 400 to 1. And the ratio in Palo Alto is 137 to 1. So I just told you, where did the kids need help learning to read? East Palo Alto. Where are all the people able to help them? They're working in Palo Alto. These are results of policy. They are decisions that we make. We fund education based on property tax value. That's a decision we make. Other countries don't do that. So these are policies. They have to do with resources. They have to do with power. And it's why the children thrive or thrive less, depending on where they live. So none of this is an accident. And in the middle of all of this, after seeing kids for all these years and getting increasingly frustrated, I decided to take a sabbatical. So in 2016, I moved over to the Graduate School of Education, the GSE, on campus, and had an office in the Saris building. And it was really amazing. I broke up with my email, my Stanford.edu, my L Chamberlain. I broke up with it. I'm like, I'm not looking at this anymore. I found it really hard to stop looking at it. I had to own that. So I set up a new email, happysabbatical@gmail.com. And I got like 3 emails a day from my fellow and a couple really important people. So I really tried to shift my world over there, and I had a desk there and an office, and I started talking to everyone, and I really wanted to understand, what can I do? What can the field of pediatrics do? What can we bring to these clinical encounters? So I've mentioned school readiness a lot. What is that exactly? So kids who start kindergarten ready have really kind of 5 domains. There are different ways people define school readiness, I learned, but this is a commonly accepted one. They have physical well-being and good motor development. They have social and emotional development. They have good approaches towards learning. They have language development, including emergent literacy, and cognitive and general knowledge, including early math and science. So kids who do start kindergarten ready are more likely to succeed academically. They're more likely to read at that critical third grade reading level. They're more likely to graduate high school, to work, and to have better adult health status. And so you can see how this is really a critical trajectory for the health and well-being of kids. And the AAP has a policy statement about how important optimizing school readiness is. So I was really coming, not late to the party, but obviously the AAP had been thinking about this as well. And all of our slides, all of these slides have a QR code that'll link directly to the source document if you're interested. So I can imagine maybe at this point in Grand Rounds, you're like, why are we talking about this? Why is a pediatrician thinking so much? Does it make sense for us to be spending so much time thinking about education? Is that really what we were trained to do? And I think that's a fair question, but for me, the answer is yes, and this is kind of why. As I spent time over at Saris, I started thinking about the early childhood system that we have in the United States. It's less of a system and really more of a kind of random set of things. And so when we think about the trajectory for kids, so 100% are born in the hospital, that's shown at the top. And then when kids get to 5 in kindergarten, about 100% go to kindergarten. But between 0 and 5, I think of it as like holding marbles and you just kind of drop them on the floor and they go everywhere, right? Like they just go in all sorts of directions. We have no comprehensive system that takes care of our kids all the way through. So from 0 to 2, we tend to think about childcare. So about on the left there, 16% of kids across the US, so this is US data, go into childcare. About 84% have no formal childcare at all. So they're either in informal childcare settings or none at all. 3 to 4-year-olds, about 60% go to preschool and 40% do not. And so when we think about that, we can see that we're not really having any one particular area that's able to touch all the kids except for the health sector. So that we know that when kids are born, they're born in the hospital, they come in for that well child check, they're seen at 2 months, 4 months, 6 months, et cetera, all the way through 5. So if you really want to touch all the kids in 0 to 5, engaging with the health sector is the way to reach those hardest to reach kids. And these are really critical years. 0 to 5 are incredibly important. Over the last 20 years, the science has really evolved, rapidly evolved in terms of how we know so much is happening there in those brains. And Paul Fisher's here, he can validate this for us. More than 1 million new neural connections are formed every second in the first few years of life. You can see some cross sections here on the left. The neuron field is thin, not a lot going on at birth. By 6 years of age, incredibly dense, right? And then by 14 years of age, there's been pruning. So the brain actually remodels, drops off some of those pathways that aren't as important and strengthens the ones that are. And what really develops this is this reciprocal serve and return interaction. So when parents and kids are talking to one another, when they're hearing language, when they're interacting, that's how they do all, it really promotes all this development and helps with the pruning. So what can we as pediatricians do to make sure all of our parents are doing what they can to maximize these important years? So that really became the focus of my sabbatical and really the last research or the last decade of my research. So Dr. Mendoza, who's here, and Tom Robinson really pounded into me, when I was a fellow, if you're going to start anything, the first thing you do is start it with a lit review. And so at the beginning of my sabbatical, I started working with Dr. Jamie Peterson, who was our general peds fellow at the time, and Dr. Suzanne Loeb, who became an important colleague and collaborator of mine at the School of Education. They said, let's look and see what do we know? What does the intersection of health and education look like in the pediatric office? And there wasn't literature that had summed that up. And so we wrote a state-of-the-art review article that did sum up the state of the affairs in 2018. So what we found, children at highest risk for not being ready for school live in poverty and or with chronic health conditions. High quality early childhood education programs can be used to help children be ready for school, but the US lacks a comprehensive system. And the early childhood education system has about half of 3 and 4-year-olds being enrolled in preschool, which is lagging behind 28 other high-income countries. And I will say that California, I showed you that US data before, we're very similar to that, a little bit worse. But we've added transitional kindergarten recently, and so that has improved a little bit. So the next step after the literature review, and this is my public health training that taught me this, reinforced by Dr. Janine Bruce, is that the next thing you do is you listen to the community. So we started engaging with the community and listening, and did a study where we looked at parental attitudes, behaviors, and barriers to school readiness among parents of low-income Latino children. And so what we heard was that over 80% of the caregivers find education very important. The parents we didn't have to convince them that this was important, and they do engage in school readiness behaviors. But they also articulated a lot of barriers that they had. Language barriers, access to books at home. Many did not have any books at home. Constraints on nightly reading, difficulty completing school forms, and limited time with their children. So this is something that people value, but we're struggling to help their kids be ready. And this study we did at Fair Oaks and partnered with Neil Patel, who at the time was one of the pediatricians at Fair Oaks. So thank you, Neil. So we continued our listening tour. Next question we were interested in is, what do parents think about doing this in the pediatric office? Did this make sense to them? Were you gonna, does that make sense, or is that gonna seem strange? And so we did this work with Jekka Steinberg, who at the time, she's the lead author, was a medical student, now a physician, OBGYN. So we found that caregivers viewed pediatricians as trusted experts. We heard that over and over again. And they said they would welcome pediatric-led guidance on this around education and early learning and development. And while they welcomed this, they emphasized that I'm worried they may not have time. My doctor seems really busy, and I don't want them talking about this if they don't have time to take care of my child's medical condition, which I thought was a really good point. So they were excited about the resources in the community, but they said they really weren't interested in the resources if they lacked cultural alignment. So one I remember talked about, I look at this brochure and it's all, the brochure from Head Start was all Latino kids. And so, it was a Black family. They're like, I don't want to send my kid there. So the cultural sensitivity and awareness around these resources was really important. So at this time, we were ready to move into some feasibility testing. And this was led by Dr. Reshma Thadani and Melanie Ramirez, who is now a medical student at UCLA, which we're very proud of. And our main findings here was we were really interested in talking to all of the clinics in our region and seeing what they were doing. And was it feasible to bring some of these resources into the clinic, or was it just too busy and too crowded? And what we heard was that pediatric clinics are being used now as platforms for promoting school readiness in some ways. Things like libraries and talk, read, sing, and murals, and I'll tell you more about that in a little bit. And that providers and staff, we talked to both, very much supported clinic-based school readiness initiatives. So they thought it was important, and they said they would be interested in doing it. So at this point, we're ready to move more into intervention mode, and started to talk about what Jamie's main intervention could be for her fellowship. And so she worked with Kinder Ready Coaching and set up a system at Fair Oaks to examine how coaching intervention for low-income kids could make a difference for kinder readiness. And really want to point out Dr. Lynn Huffman was a big help on this one. So the main findings, so what happened was kid would come in for their 4-year-old visit, and they would get randomized to get the coaching or not. And the kids that were randomized to get the coaching would sit down with a community health worker, and the community health worker would assess the child and see how they were doing in terms of the things that they would be assessed on when they went into kindergarten. There's a kinder entry assessment for every kindergartner in California. So they assessed the child with that kinder entry assessment and noticed like the child needed a little more help with, fine motor manipulatives, or needed a little more help with working on reading, etc. So at the end of the assessment, they handed the family tools for that. So fine motor stuff, handed them little manipulatives, etc. And then that was it. That was the whole intervention, 1 hour assessment and then some tools. And then what we did was we called the family a year later. And we said, tell us about this. Do you remember this? And did you do any of the things that the coach recommended? Every single parent remembered. They remembered her name, many of them. And they said it was a really important conversation. It really stuck in their heads. So they reported that they were more likely the only things that really were statistically significant, more likely to tell a story, to tell their child a story and visit the library within the last week of when we called, and less likely to report barriers to school readiness. So we did find that this brief coaching intervention could change things a little bit. So Dr. Peterson then went off to OHSU, where she's killing it, doing a lot of great kinder-ready work. In the meantime, I had been talking with Dr. Loeb, and it was unbelievable. Right at the beginning of my sabbatical, it was Sunday, and I was reading in the New York Times, and I'm reading this article about this Tips by Text program. And I'm like, oh my God, this is like exactly the kind of thing I'm interested in. And it's, they're texting kids, parents to help the kids be ready for literacy. And I'm like, where is this? Stanford University graduate school. I'm like, shut up. Like, this is unbelievable. And so I couldn't believe it. And it's Suzanne Loeb. And I'm like, oh my God. And so I said, I didn't even know we were doing this. So she and I went to Tressiter. And I always remember sitting there and we're having a cup of coffee. And I'm like, Suze, this is like the coolest thing. Tell me more about it. And so she tells me all about it. And she said, yeah, we tested it at Head Start. We texted the parents at Head Start and all these different Head Starts in Daly City. And it made a huge difference, and the further behind the kid was when they started, the bigger the gain was, and, all this stuff, and help them develop their literacy. And I said, well, I would love to do that in clinic. And she said, okay, well, the clinics, tell me about the clinics. I'm like, oh, it's like Head Start. It's, a lot of immigrant families and Spanish speaking, fabulous. And she's like, right, well, I've already tested it in those kids. Like, why would I do it in clinic? And I said, no. Like in clinic, my kids in clinic, they don't, the ones who've been to Head Start are the ones that are more likely to be kinder ready. Like, those aren't the ones I'm worried about. I'm worried about the ones who don't get into Head Start because there aren't enough spots. And she said, oh, right. Okay, I hear you. She goes, we really tried to reach those kids. They were really hard to reach. Like, they're in informal childcare and we just couldn't reach them. It doesn't work. And I was like, okay. They come to my clinic. They're all there. It's that box. She was trying to reach the ones, on the right there that weren't anywhere, right? And she went, oh, yeah, we got to do that. And that's really what kicked off our whole transdisciplinary research. So transdisciplinary research defined as an approach that integrates frameworks and methodologies beyond our disciplines. I don't know what to text them. I am not an expert in how to do that, but she knows exactly what to do. She can't reach them. I can reach them and I can codify it with a stamp because parents trust us at the doctor's office. And so leveraging the access that we have is really the key. So together we put together our hypothesis that health clinics and providers are organizations that can improve literacy levels in young children from the most disenfranchised families. This really continues to be my North Star. So we brought her text messaging program to support parents in preparing their children from kindergarten into an RCT with a qualitative component. So let me tell you a little bit about this. So she and her colleagues have developed suites of texts, so large sets of text that are sent 3 times a week for 7 months to parents of 3 and 4-year-olds with tips on how they can educate their kids at home and get them ready for kindergarten. So there's a ton of science behind these texts. They use empowerment models and behavioral change models, and these brief messages break down recommendations into these tiny bite-sized pieces that really work for busy parents. And they're scaffolded. And what that means is think of like a spiral staircase. They start in certain ways that are basic, and then they build on each other. And then they also repeat the important things. So there's a lot of science behind the text that she's put together. So here's some examples of what they say, what a parent would get. On Monday, on the way home is a great time to build your child's knowledge of sounds, letter sounds. Children who know letter sounds are better prepared for school. So there's nothing to do there, right? It's just, this is a fact. On Wednesday, on the way home, ask what animals start with the B sound, B, bear. What letter makes the B sound? So that's something that the parent could do driving. And on Friday, it says, good job, keep working on your letter sound. So it's just kind of a coaching thing and then an opportunity to repeat. And you might notice that they all start with doc says. So, this is texting. We're trying to get as many, as few characters as possible, but your doctor says. So these were coming from the doctor's office. We were prescribing them. And this was different from what she'd done in Head Start. We were curious about the power of the physician's voice, and did that matter? So that's kind of what the text looked like. And so where we did this was down at the Valley, our beloved Santa Clara Valley Medical Center, in 2 very busy county-based primary care clinics. Very indebted to Steve Harris there and Jenny Foreman for helping make all this happen with us. We enrolled 3 and 4-year-olds who were English and Spanish speaking, who didn't have developmental delay and were not in preschool. We assessed them with the PALS Pre-K, which is a language assessment that was validated in English and Spanish. And so what we ended up seeing, kind of overall, table 1 here, we enrolled about 644 kids. And typical for what you would see at the Valley, about 2/3 were Latino, 40% of those spoke Spanish. Caregiver education levels were about 1/3, less than high school, 1/3 high school, 1/3 some college, and most were moms. So the first thing I was really interested in was understanding of what I was seeing in terms of whether or not kids in preschool were really different. So my sense was clinically that the kids who got to Head Start were a different group of kids than the kids who didn't. But there was no literature on that. That's never been shown. And so we were able to look at, because if kids were in preschool, they were excluded here. So on the left are the ones who were in preschool and the ones on the right were not. The ones who were not in preschool had less, the parents had less caregiver education, more likely to be Latino and more likely to be Spanish speaking and more likely to be lower income. So it is a distinct group. What we showed was we are the ones that see the most vulnerable kids. So those kids that never interact with Head Start, never interact with preschool, you are only going to reach them if you interact with the healthcare system. And then, of course, table 1, super important, no difference between the intervention and control. Randomization worked. So what did we find? After 7 months of text in our first model, the overall treatment effect without any adjustments was 0.26, so a significant p-value there. And that's one thing I learned in School of Education. They don't think about p-values. They don't even care. They're all about the treatment effect size. So I was like, okay. Model 2 adjusts for the baseline pre-K score. So where did they start and adjusting for that, and even more significant. And then model 3 adjusted for the the baseline score, the age and language of assessment language, and even more significant, being a 4-year-old really made a difference compared to the 3-year-olds. And so we have these effect sizes and these p-values, and I was really like, I don't really want to write this up this way. What does it mean? What does it mean in real terms? And based on model 3, we were able to quantify the literacy gains for kids, and there was a 3-month literacy gain for the kids in the intervention group compared to those in the control group over 7 months. So the kids who were getting these texts had a burst of 3 months of literacy development compared to those who did not. So really, I think, clinically significant increase. So we were able to write this up. And again, just really want to thank, it was a huge team effort, but Lynn Huffman held my hand through the entire thing. And not only that, she helped me with the very first study I did here as a fellow. And so huge debt of gratitude to Dr. Huffman. In addition to the quantitative analysis, we did some great qualitative analysis led by then a medical student, now Dr. Elizabeth Conley with Dr. Bruce, looking at clinic school readiness with this texting program. And what we found, what we heard, were novel ways for using texts. They were shared widely with others. And I was like, great. I hope they weren't texting the control group, but okay, can't control everything. Parents leveraged the authority of the voice of the physician, increased focus on academics, and they really did like the texting. So I'd love to bring the parent voice into this a little bit. A Spanish-speaking parent said, I feel more comfortable making direct and specific questions about things that she might not be able to do. For example, if she was unable to distinguish between colors, I would notice. Another Spanish-speaking parent, it has also helped me because I can say, the doctor says he wants you to draw. So he starts to draw. It has helped me a lot because I only have to say the doctor says to for him to do something, because sometimes he doesn't want to. So again, that doctor voice. Another Spanish-speaking parent, every time I would get the message at work, I thought, how am I going to ask him this question? Or how am I going to do this? We started talking more, dialoguing more between the two of us. And an English-speaking parent, oh, I think the texts are very handy. I actually started forwarding some of them to my friend, just as little tips, especially with the reading, writing, because most of our kids are all in the same age too, and they're all in that stage. So I think it's really wonderful to hear from the parents. So based on that feasibility, and we successfully applied for an NSF grant and went into looking at how can we use texting to promote math in addition to literacy in rural Oregon. This was led by Dr. Peterson and our team. One of the things that we did differently here is we took the texts and we had the parents look at them and think them through and tailor them some. So it really was community-informed transdisciplinary research because some of the texts needed to be tailored a little bit. Unfortunately, we really struggled with enrollment on this. We were not able to get the number of kids enrolled, and I'm happy to talk about that in the Q&A. But the qualitative analysis is underway. So want to move into Act 2 at this point, moving from the transdisciplinary research to some team science. And it's as we've been going along, there's been a lot of other things happening in the background that I'll share with you, and it all comes together at the end. But just wanted to stress that the North Star really did not change, in that we're still exploring how pediatric settings can improve kinder readiness. So one of the really exciting things that happened in 2021 here on campus is that Dr. Phil Fisher was recruited to lead the Stanford Center on Early Childhood. And the vision there is to see that every child can thrive from the start. That begins with families, educators, and communities that surround them. So unless you've tried to do transdisciplinary work on this campus, you might not get how big of a deal this is. Here's our campus, and there we are at the med school, and there's the GSE, and it doesn't look that far apart. And yet it can be really tricky to do the work. And what's really wonderful about the Stanford Center on Early Childhood is it's really designed to be a bridge, designed to help pediatricians who care about this work partner with their colleagues in the Graduate School of Education. And Dr. Ryan Pedrez has been absolutely critical in this establishment. He has extensive experience working in the community and education as the medical director of the primary school, and he was really instrumental in bringing Dr. Fisher here and is one of the co-directors at the Stanford Center on Early Childhood. So very excited to partner with him, and there are some other faculty from around DB Peds and some other places who are also a part of this, and we welcome any and all who would like to be involved. So as we kind of are moving into solving these problems, our team is growing, which is really exciting. And at the sense, I really want to stress how at the center, they really think and do things kind of differently, which I love. Here's a headline from last year. They bring together lots of folks to talk about educational policy and in a really bipartisan way, and how can we support kids. So it's been really fun to watch the center as it finds its footing. Another thing that happened then in 2023, Medi-Cal had a new benefit, and that was to support community health workers. So that's a new reimbursable service. And so again, going back to the literature, what do we know about community health workers? That sounds great, but what do we really know about them in pediatrics? And there's really not much there. So as a part of the First 1,000 Days Special Interest Group at PAS, I, with Tumani Coker, we helped co-found this group, and we did a literature search together and review and wrote this up. Not a lot is known in terms of pediatrics and child community health workers. 28 states now, though, do have this Medicaid benefit, while 25 have CHWs for adults. So CHWs can be a possible team member thinking about kinder readiness, but when you work in communities, there's never a dull moment. So we're going along, and all of a sudden, I hear Jackie Spear has come back to town. So Jackie Spear, many of you probably know, 40 years of public service, served in Sacramento representing our area, and then went to Congress. And she returned back home after that time to address child poverty. She says, "Together we can end child poverty in San Mateo County." And I was like, ding, you've got my attention. Very curious about this. And her idea, she was very invested in the child tax credit and was frustrated how it was eliminated after COVID. And so she wanted to look at how could we provide a guaranteed basic income, like $300 cash a month to families for those first 3 years, lifting them out of poverty, and how would that change our community. At her community launch, because of the work I'd been doing in kinder readiness, she asked me to speak. And so I was able to talk about how I thought pediatrics would be an important part of this system. And that launch brought together many leaders from across the county. We were all together, and a lot of us also from Stanford Children's. It was really a wonderful day to talk about these issues. You had First Five there, County Board of Supervisors, Health Plan of San Mateo leadership was there, Human Services, San Mateo County Health. So everyone was together, and in the discussions that we subsequently had, two things became clear. Stanford is the delivery site for about 75% of the Medicaid babies in San Mateo County. So if you want to enroll babies, new families, in a guaranteed basic income program, our nursery would be a great place to do it. And number two, we learned that Health Plan of San Mateo was very interested in investing in community health workers. So that was exciting. So together, we all decided we would join together to form the Baby Bonus program. And we really put families in the middle. We said we need to talk to the families first and hear what would they want the community health workers to talk about? What is of priority for them? So together, this group of community folk and us, Brian and I and Dr. Fisher, came together to put the hypothesis together is number one, do community health workers improve health service utilization? So well child check attendance, the maternal postpartum check. Do they change social service utilization? So do they enroll more in CalFresh? How about engagement with CPS or Child Protective Services? Is that less? And can they change child development trajectories? And we'll be assessing that with the Bailey. In addition, for those getting the cash, does this change their family economic indicators? Family stress, are they able to meet an unexpected $400 expense, et cetera? So as we were developing these hypotheses with our community, we realized, Dr. Pedrez and Fisher and I, we don't have the background or frankly the data to be able to look at all these outcomes. And so we started reaching out, building out our team, and reached out to folks in population health sciences, Melissa Bondi, David Rakoff, Leslie Sept, who have been amazing partners with us. We then reached out to kind of the health policy and health economics group, David Grusky, Adrian Sabatier, and Sarah Chamberlain were all wonderful partners. Melissa, David, and Adrian kind of helped us get started and are less involved today. The rest of us are continuing to work together in this team science approach. So the way team science is defined, a collaborative effort to address a scientific challenge that leverages the strengths and expertise of professionals, oftentimes trained in different fields. And this is just really critical. And I think that when we think about trying to address complex problems, picture the trees, right? Like that's super complex. There's so many things going on. This can't be a single PI-led question. It really needs to be addressed by a wide range of people who are thinking about a lot of different approaches. So when you bring the whole project together, it looks something like this. So on the left, we have all these committed folks from the community who are listening to the parents and suggesting interventions that they believe have potential to scale. So the County Board of Supervisors is invested in this. The health plan is invested in this. They said, if we can see these results, that we can improve our metrics in terms of getting kids to well child checks, keeping kids out of the ER. The state has new expectations for health plans to be doing this. They are willing to invest in these kinds of solutions. And I'm just really struck by how these are timely questions, local problems, but they have national significance, which has always been the sweet spot I've always been looking for. How can we make a real difference here on issues that have national consequence? And on the right, you've got these world-class scientists working together in partnership with the community to add to the literature in really meaningful ways. So to test our hypothesis that the community helped us develop, in April of this year, we launched the Baby Bonus trial. After all of us working together for about 18 months, we were able to launch the trial. The trial is being run out of our newborn nursery at Stanford, where moms on Medi-Cal who live in San Mateo County are eligible. The goal is to enroll 1,200 families, making this the largest trial of CHWs in pediatrics in the country. Ryan Pedrez, David Rakoff, and I are the co-Is on this. And I really want to highlight the our three research coordinators. Thank you. Yes, because they are killing it. They are doing such a fabulous job going in, talking to the families and enrolling them in this trial. We have 50% of parents saying yes to this, which is really a remarkable uptake given the context of our world right now. Really also want to call out the newborn nursery staff and Luann Smedley from the Johnson Center. That woman can make anything happen. She can solve any problem we throw at her. She's remarkable. So the rollout has been relatively smooth. It's been really fabulous. So the trial has 3 arms. Group A, if you're randomized to Group A, as a family with a newborn, you receive the coordinated services from the community health worker. So you're matched with the community health worker. And right now we've enrolled 73 families in that arm. Group B, you are randomized to get not only the community health worker, but this bonus. So $300 a month for 3 years. In Group C, you receive our usual care. So we've enrolled almost 300 families total of 1,200. So we're about 25% of the way there. And yeah, so stay tuned. A lot more coming on that. Please invite Ryan to come and give grand rounds to share the results as they roll in. So if we have positive findings, I think it's just really remarkable that the idea that we could change our systems to help that case at the beginning, our 4.5-year-old, if that is a kid who had the community health worker, who had gotten the resources they needed, help enrolling in preschool, given a lot more support, change their developmental trajectory, could we help those kids all be kinder ready? Could we, as a healthcare system, be a part of an early childhood system that changes that early trajectory? So that's kind of the goal and the dream, that we could help be a part of this integrated system in a really sustainable and scalable way. So moving into Act 3, those of you who know me know that there's no way I could give this talk and not talk about our current context and talk about how can we, in a really robust way, meet this moment. So the last part is a mindset for success. And there's kind of two things that I've been reflecting on over the last year of how we can meet this moment in a thoughtful way. And number one is to take the long view. And the second is just get busy. So I think these are key, and I know many of us can sometimes feel discouraged with many of the values and things that we care about, things like science, things like vaccines, being dismantled. So let's start with taking the long view. And I really want to shout out to Dr. Paul Wise. His thinking and writing on this with Julie Richmond years ago has really informed what I'm about to talk about. So with that credit, taking the long view, I would not be talking about kinder readiness if we didn't have kindergartens. So let's go back in 1838. The first US kindergarten was established in Columbus, Ohio. 1889, the Hull House was founded. Folks know the Hull House? All right, a little bit, not much. Okay, so this was part of the progressive movement into the 1800s. A woman named Jane Addams, with a lot of other women, went to Europe and learned about these homes that were established in urban areas. This is a time when people are moving from the farms in a more agricultural life into urban settings. And they realized a lot of families, women and children, needed support. And so these were homes that really supported our communities right at the beginning. The women became a really powerful voice for children and families, and a lot of child-friendly legislation came out of it. Child labor laws, protecting dangerous work couldn't be done by children under 16, et cetera. So a whole series of things came from this progressive movement. 1962, fast forwarding, NICHD was founded. 1965, we added Medicaid and Head Start. And in 1997, State Children's Health Insurance Program, now called CHIP. So we've had a lot of wins. When you look back, we've had a lot of wins, and that's really important. But there's something that happened that I want to draw your attention to that I think really helps us today, and that is that in 1921, the Shepard-Towner Maternity and Infancy Act passed. And this was really the first federally funded social welfare program, which provided maternal and infant health services, aiming to reduce high infant mortality rates through prenatal clinics, health education, and visiting nurses, and really made a significant difference for kids. The American Medical Association strongly opposed this act. They said it was socialist, and they said it threatened the profession, and they advocated vociferously to have it repealed. The pediatrics section within the AMA disagreed, and they argued and advocated for its renewal. The act was repealed. So we had something in place for 8 years that pediatricians saw made a big difference, and it was repealed. We lost it. When the pediatricians supported it against the will of the AMA, they were formally rebuked by the full House of Delegates. So they were publicly scolded, and they stood up and they walked out. This led to the forming of the American Academy of Pediatrics the next year. The pediatricians, along with the progressive women who had worked on the Hull House, continued to advocate for the ideas that were in that act. And when the political headwinds changed, the 1935 Social Security Act passed. And within that act, it had a lot of the infrastructure and pulled forward things in the Shepard-Towner Act and reinstituted them. And that was 14 long years, 14 years that between when they lost what they had and when they were able to get it back. So this is not a sprint. And yet, with time and with solidarity, they were able to stay the course and fight for kids and get what they needed. So what I would challenge you to do is think about what's next. A new pediatric organization, new laws, a new NICHD focused on team science, a commitment to child kindergarten readiness for every child in this country. There are opportunities with this kind of disruption and this kind of time that we find ourselves in. So I think actually right now, it's a great time to be a pediatrician. It's a great time to be a pediatric researcher. We have a front seat in history right now. And I think we'll look back and ask ourselves, what did we do with it? So taking the long run helps. It helps me a lot. The second thing is just get busy. I think bemoaning the situation is not helpful. I get it, and it's not helpful. So ask yourself, and I heard this from Kim Schreier, who's our pediatric representative in Congress from Seattle, West or Eastern Washington. What are you good at? What are you good at? Are you good at talking to your neighbors? Are you good at raising money? Are you good at whatever you're good at? Just start doing that. And so one of the things I'm good at, I love to bring people together. I love to lead coalitions. 10 years ago, I started a group called Impact, the Mid-Peninsula Pediatric Advocacy Coalition. Brings together folks from Stanford, Gardner-Packard, our nursery, and then all of our community clinics, Ravenswood, Mayview, Fair Oaks, Daly City, Coastside, Half Moon Bay. We've been working together for 10 years. No one gets dedicated time to do this. We just vote with our feet. We all take care of about half the kids on the peninsula taken together and 100% of the kids on Medicaid. And so together, when we take action, we really are reaching a population of kids. These are my fabulous colleagues across all of those clinics who have really become good friends. We meet every other week on Thursday, 8:15 to 9:15. You're all welcome. We have worked together to address food insecurity, mental health, a whole bunch of things. But for today, I'm going to tell you what we have all worked together to do about making our clinics more kinder ready. There are 4 domains that we have worked on: changing the physical environments of our clinics, increasing the tools of early learning, coaching, and role modeling. So this is what the waiting rooms typically look like. So I want people to think about what the waiting room, if they've taken their children, or if you can remember your waiting room when you went. Did it look this bleak? Probably not. So what do our clinical settings say to our patients? We worked on changing those environments so that they look like they look when you walk into a private pediatric office. This work was helped to be led by Jekka, and she wrote this up. What do clinical environments say to our patients? A replicable model for creative advocacy. So here's the Mayview Clinic. The before shot is on the left, after is on the right. You can see the little plant made it. We let the plants stay. But everything else has been really transformed. And so this is just an example of kind of creative ways to really speak to the families. One thing that's interesting, I was talking to the office desk staff at Mayview, and I said, so how do you guys like the new mural? They're like, it's so nice. It's so much nicer to walk in here. And you know what we noticed? The parents were on their phones less. Could have studied that, but I didn't, but I should have. Okay, so changing the clinic environments. Other things, increasing the tools of learning. Getting those books into the home, getting the things the kids need. So one program is called Talk, Read, Sing. These are bundles that we put together. This comes out of the Clinton Foundation, the Too Small to Fail work, and they provide these materials and these little graphics, the little cartoon kids. And this is part of the California's First 5 campaign. So you'll see it on bus placards and laundromats, etc. So with this little motif, we provide in the nursery when babies are born, a little packet that has the book and a t-shirt, and we say, congratulations, your breast milk will help the baby, body grow, and the book and talking and reading and singing to your kid will help the brain grow. So right from the beginning, they're getting that message, and then they go out to our clinics at 9 months, they get the same message, and at 18 months. Other tools of learning, we've created little libraries in all of these clinics, and these are bookshelves full of gently used donated children's books, and families can take as many as they want. Nothing. At first, we were having these conversations like, what if they take more than one? How are we going to? And I'm like, is that really a problem? If they want to take more books, I say they can take as many as they want. So we've distributed about over 20,000 books since 2016. Coaching, we've talked about the tips by text. We are texting families out of Ravenswood Family Health Center. And then role modeling through story times. This is something that we were doing before that we've brought back. We had to stop it during COVID, but Stanford undergrads go. They sit in the clinic on the floor reading and role modeling to families how to share books. We have, and I really want to call out Emily True from our office. She has helped to stand this up with us. And there is also not only a class, PEDS 129, which started last Tuesday. I'm going to go do it this morning at 10. Little libraries. So it's a course where the students come and learn about the importance of early literacy. And on Tuesdays and on Thursdays, they volunteer in all of our clinics. And then there's also a club called Little Libraries. So those are the students sorting the donated books and getting them out to the clinics. So what's interesting is that all of our literacy work in the community, people here started to hear about it. And so there's a new group that's called the Pediatric Literacy Launchers. These are subspecialists who are interested in getting books into their clinics. And so lots of fabulous people that you see here from our friends in cardiology, DBPEDS, endocrinology, emergency medicine, led by Dr. Reshma Thadani, very appreciative. They have distributed over 400 summer learning kits, and we've set up little libraries in many of our clinics here at Packard. So just get busy. There are lots of ways. Early literacy may not be your thing. That's fine. If it is, there's lots of examples here of how to participate. But if there's a different topic that you're interested in, please reach out to our OCHE. We have many community partners and would be happy to help you get engaged with that for which speaks to you. So in conclusion, pediatricians can and should leverage their unparalleled access to 0 to 5-year-olds to become a more important part of our early childhood system in the United States. I think we have an opportunity to advance rigorous team science to address the complex challenges that children and families face today. But we need more evidence-based solutions. We need them to be community-driven to support kinder readiness. And I think Stanford is absolutely a great place to do this work. And this really is our moment. And it really is a privilege to be able to do the work at this important time. So I really want to thank you so much for the chance to be here. Upper left there, Julia and Janine, key to our team. Couldn't do any of this without you. Really want to highlight Emily True, who's done extraordinary work and helped me with these slides. And just all the folks. It's really such an opportunity to be here and to get to work with everyone. Couldn't get the work done, and it certainly wouldn't be any fun without everyone. So really appreciate it. And of course, to Mary, whose leadership of our department makes all of this happen. So thank you very much for your time today. This is Jane Addams, the founder of that Hull House and the first woman to be awarded the Nobel Peace Prize. So thank you very much. Happy to take any questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.